blood supply of brain will be discussed. It has anterior circulation coming from ICA, continuing as MCA inside the brain, giving branch ACA, anterior cerebral artery, anterior choroidal artery, ophthalmic artery, posterior communicating artery. Okay, then we have posterior circulation coming from vertebral arteries, two vertebral arteries joining to form basilar artery. It has terminal branch of posterior cerebral artery. First we'll discuss about anterior circulation. We have common carotid artery bifurcating at the level of C4 into ICA and ECA. ICA will enter carotid canal of temporal bone, and then it passes through cavernous sinus. Inside the brain, it continues as MCA but has branches, that is ACA, anterior cerebral artery, posterior communicating artery, ophthalmic artery, anterior choroidal artery, and communicating as MCA. MCA. Okay, let us talk about symptoms when each level is affected. When ICA is affected, carotid stenosis there or something like that, then MCA is affected, ACA is affected, also ophthalmic artery is affected. Therefore, the patient will also have a short period of blindness called as amaurosis fugax. Okay, when CCA level only it is stenosed, you will also has a feature of ACA. Maybe jaw claudication can be seen along with all these symptoms. Okay, then coming to anterior choroidal artery, which actually supplies it supplies posterior limb of internal capsule. So draw internal capsule, we have posterior limb supplied by anterior choroidal artery, but it has collateral, so not much of a damage will be seen. If there is complete occlusion there, then lower posterior limb internal capsule, then you will have contralateral hemiplegia. Okay, then you have homonymous anioniopia, but good collaterals is there, so less effective, less symptoms will be there. An important cause of this choroidal artery disease occlusion is mainly iatrogenic, that is due to surgical clipping of any aneurysms nearby. You may injure and occlude this anterior choroidal artery, surgical cause. Okay, then let us talk about ACA. ACA has two parts, A1 and A2. Before anterior communicating artery we call it as A1. After communicating artery we call it postcommunal. Okay, A1 has a supply for internal capsule, anterior limb of internal capsule is supplied by A1. Also it supplies amygdala and anterior hypothalamus, AAA, all is. They also have a good collateral, so less clinical features will be seen. This mainly ACA will supply the inner part of the medial part of the brain, cerebrum. Okay, let us talk about MC. MCA also is divided into M1 and M2 at the level of sylvian sulcus, where it divides into superior and inferior branch. It will be called M2. Before that it will be M1. So it gives before bifurcation, M1 part has two branches. It gives branches to lenticulostriate artery, and it has cortical branches. Okay, lenticulostriate branch will also supply internal capsule. Okay, then putamen caudate nucleus will be supplied. Cortical branches, the outer lateral part of the cerebrum will be supplied mostly by MCA artery. Okay, now injuries of MCA. If at the origin of MCA only MCA is affected, then you will have contralateral hemiplegia, hemianopia, hemiasthenesthesia, facial weakness, If it involves dominant hemisphere, you will also have global aphasia. If it is non-dominant, you will have anosia, that is half of the picture or object will be neglected. Then you have partial occlusion, only single branch is involved, either hand or arm weakness can be seen. M2 has superior and inferior part. Superior part will supply frontal lobe and parietal lobe, so this will be affected when superior part is occluded. M2 inferior part will supply inferior parietal lobe and temporal lobe. Okay, therefore when low inferior division of M2 is affected, you will have fluent aphasia, temporal lobe, vernicus area, fluent aphasia will be seen. Okay, then we have lenticular straight branches. When occluded, we will have just pure motor stroke. Now coming to posterior circulation. Posterior circulation has vertebral artery originating from right innominate artery in right side and left innominate artery, left subclavian artery from left side. They enter transverse foramen of C6 and till C2 they will go. This will be part 1. From C2 to dura mater we will have part 2. Okay, now we have piercing of vertebral foramen, dural piercing of vertebral artery. Then they will two vertebral arteries will join to form basilar artery. Basilar artery has many branches: posterior inferior cerebral artery, anterior inferior cerebellar artery, short circumflex, long circumflex, and it will also have paramedian branches, and then it will continue as PCA, posterior cerebral artery. Okay, this PCA when going to cerebellum, it will also supply medulla. So syndromes are called lateral medullary syndrome. When ICA is going towards cerebellum, it will also supply lower pons. Therefore, lateral pontine syndrome. Short circumflex will supply mid pons. Long circumflex will supply upper pons. Midbrain is supplied both from the branches of either basilar artery itself or from PCA. Medial part of all these brainstem structures will be supplied by this paramedian branch. Pica also on PCA can also be divided into P1 and P2 depending whether it is proximal distal to communicating artery. Proximal will be P1, distal will be P2. P1 supply subthalamus and thalamus. P2 will supply temporal lobe and occipital lobe. That is written here also. Medial part, all medial structures will be supplied by paramedian basilar artery. Lateral structures, midbrain, PCA. Upper pons, long circumflex, mid pons, short circumflex. Lateral pons, ICA, lower pons, ICA, and medulla, pica. Medulla can also be supplied as direct branches from vertebral artery. Important thing is occlusion of which artery leads to which syndrome they will ask. Let us recall the brainstem syndrome. We have medulla, midbrain, pons and medulla. So they will ask which artery is affected. We have pneumonia, WBEC, Rocky Mountain spotted fever, L, and then we have DJ well baby. Okay, that is Weber, Benedict, Claude, Raymond, Millard Gubler, Foville, and then Locked syndrome. D for Dijonie, then for Jackson, then we have Wallenberg, then B for Babinski. As a this W Weber will be medial structure, DJ will be medial structures. So medulla, medial, all medial. You will have paramedian basilar artery occlusion. Okay, along with that lateral. Now we will lateral. Claude is lateral. These two will be lateral. So medulla lateral, which will be supplied PCA. Okay. What is this? Sorry, midbrain lateral PCA. Medulla lateral, you will have medulla and lateral pica. PICE. That is what I said. Lateral medullary syndrome.